And we are conducting this meeting in the form of a webinar. All know that the outbreak of COVID-19 started in 2019, and in the past few months, China has accumulated rich experience in the prevention and control of COVID-19. And it's our honor to be joined by two Chinese experts who have been working on the front line of the fight against COVID-19. They will share with us their first-hand experience. Today's topic is COVID-19 clinical diagnosis webinar. It is a good platform to share with you Chinese hospitals' experience fighting this disease. In this way, we can finally win the battle against our common enemy, COVID-19. So now I will give the floor to the first speaker, Director of the Laboratory Department of Beijing Ditan Hospital, Professor Wang Yajie. Her topic is China's clinical guidance for COVID-19 pneumonia diagnosis and treatment. Right now, this guideline is the 7th edition. Professor Wang Yajie is the director of the Laboratory Department of Beijing Ditan Hospital. She is also a visiting scholar at Boston University, USA. And throughout her career, she has published more than 100 Chinese and English papers. And she also holds 16 patents as first inventor and 6 software copyrights. She is also the winner of 2019 the 13th Beijing Invention and Innovation Championship Bronze Award. And she has also won the award such as China's well-known Doctor, Beijing Science and Technology Rising Star, etc. Now she's also the member of the Standing Committee of the Beijing Medical Association's Laboratory Branch, Biochemistry Group of the Chinese Medical Association's Laboratory Branch, Department of Clinical Laboratory Diagnostic of the Capital Medical University, Deputy Chairman of the First Youth Committee, member of the Council of Clinical Application, Biochemistry and Molecular Biology Branch at Chinese Society of Biochemistry and Molecular Biology. So without further ado, I will give the floor to Ms. Wang, Professor Wang. Welcome. I thank Professor Pan. Thank you for your introduction. Thank you for your introduction. It's my honor to be here to share with all of you. And Professor Mao, Dr. Sandren, dear friends, good afternoon. It's my honor to share with you my experience. The outbreak started on January the 12th in Beijing. So we have risen up to the challenge in laboratory testing. And China's clinical guidance has now 7th edition. And first, with the introduction of this guidance, I will talk about Chinese experience. First, what's the laboratory department's role in the diagnosis and treatment of COVID-19? And in our department, we mainly have 2 parts of job. First, the laboratory testing related to COVID-19 and the testing requirements from other departments. So to further divide our job in the laboratory examination of COVID-19, we have two categories. First, etiological examination and the testing of routine indexes. The testing has high requirement in biosafety. So actually, our workers are under huge pressure in the past few months. In Beijing, there are 3 municipal level hospital and 17 district level hospital. And our hospital is responsible for 70% of the diagnosis and treatment, the diagnosis and treatment of 70% of the patients in Beijing. So starting from January the 12th, we started the laboratory test and the treatment of COVID-19 patients. Back then, we had little knowledge, little understanding of the epidemic. And it was not until January the 20th that we treated COVID-19 as a serious epidemic. And on that day, we started more than 20 routine tests for COVID-19 patients. On January the 29th, we launched the nucleic acid testing of COVID-19. I remember that that was the first day of the Chinese Lunar New Year. And our result is exactly the same with the result from the tests conducted by China CDC. And our work in this regard has been highly recognized by the clinical department. So in this way, we can conduct testing of COVID-19 patients, providing supplement to clinical departments and providing guidance to their treatment. Later on, the number of tests has been on the rise. This is due to the increase in the number of critically ill patients. And later, we also carry out more tests, more items. In total, more than 80 tests were included and were conducted in our laboratory. And we also increased the number of items, such as the 8 items for surgery, RH blood type, etc. So to be honest, we faced pressure and great challenges throughout this period. And in February, the COVID-19 has become a global pandemic. So now we face a new challenge of imported cases. So at the peak time, we have to conduct 6 batches of nucleic acid test because the time needed for one test is 6 hours. So 6 batches is a considerable workload. And actually the number of nucleic acid tests performed made a record of 449 within one day. So this is a timeline of the work conducted by the laboratory department at Beijing Hospital. Next, I will talk about my major topic today, that is China's clinical guidance for COVID-19, the evolution, the development of this guidance. From this timeline, we can see that our understanding of this disease is evolving rapidly. Starting from the first government announcement, first notice related to COVID-19, we quickly formulated the second edition. On the second day after that, we can look at the dates of the first, the second, the third edition. There's only one day interval between them. So the modification of this guidance was the modification of this guidance was quite quickly. So I think that the 8th edition will come out soon. So first, on the preface of this guidance, looking back, the preface is quite accurate because right now the epidemic within China has been put under control, but the number of imported cases has been skyrocketing. And I've updated, I've taken the latest figures and put them into the slide. And we can see that on March the 25th, there are 67 new COVID-19 cases. All of them are imported cases. So right now, the features of epidemic in China is almost zero increase domestically, but we are under huge pressure coming from imported cases. More than 195 countries now has COVID-19 confirmed cases. So again, we have to bear in mind that COVID-19 pneumonia is highly infectious. So the Pathology department should play a bigger role in helping clinical treatment. And more importantly, we should keep our safety and protection in mind. And the second is etiology. The novel coronavirus belongs to the coronavirus beta genus, and its diameter is 60 to 140 millimeter. And its diameter is 60 to 140 millimeter. From existing data, we can find that the novel coronavirus is very different from the coronavirus causing the SARS epidemic back in 2013. Back in 2003, I was part of the control and prevention campaign against SARS. Back then, our understanding of the SARS epidemic was also not profound at all. Looking back, our understanding of the pathology of SARS and the protection needed for medical workers was kind of poor, and it took us a long time to form a complete understanding in this regard. And in 2003, in March, the US CDC and Hong Kong University Microbiology Department announced that they found the coronavirus, the pathogen for SARS. And today we can see that there's a huge difference between this coronavirus and the COVID-19. back then it took us a long time to have a full understanding of the SARS pathogen. Yet, this year, we spent shorter time in discovering the coronavirus, the novel coronavirus that is COVID-19, which was previously unknown. So this is a remarkable progress, an important benchmark for later treatment. History doesn't repeat itself, but it often rhymes. But I believe that this time, again, we can win the battle against this epidemic.
So, the etiology understanding is vital for us and to ensure the biosafety protection because it is a new virus. And so our understanding of this virus comes from SARS and MERS. And so far, given the current data, it is sensitive to UV light and heat under 56 degrees Celsius and 30 minutes with ethanol or ether, then it can be effectively inactivated. So this is the vital reference for us to conduct the biosafety protection. And the inactivation time, we choose that the 56 degrees Celsius 30 minutes. And this is effective and biosafety protection for our staff. And also, it is vital to conduct a sufficient disinfection. Now, let's take a look at the epidemiology. We can see the main transmission path are the COVID-19 virus in patients, but we can see those asymptomatic patients that can be the source of the transmission. So we need to pay attention to that as well, because for asymptomatic patients, we are not sure whether they are infected or not. So subconsciously, they can be the source of a transmission. So for this prevention, on one hand, we need to pay close attention to patients with symptoms, but also the asymptomatic ones as well. And on the transmission path, mainly from respiratory tract, the droplets, and also through close contacts. And we need to pay attention to one definition, close contacts, not the ordinary contacts, close contacts. Another point is that aerosol transmission. In the 6th edition of our clinical guidance, it pinpoints that, and that actually shows our deep understanding of this virus. It says that an aerosol transmission will be achieved under certain condition if the aerosol has a high concentration and with a relatively enclosed environment. So aerosol within our laboratory setting, it is a possible scenario. So within the laboratory setting, this is the key point for us for biosafety protection. And in our 7th edition, among feces and urines, COVID-19 virus can be isolated. And that tells us, on one hand, we need to pay attention to the contamination caused by feces and urines, which can generate aerosols. And also within our laboratory, we had the possibility to be in contact with feces and urine specimens. Blood specimens are common. Urine and feces specimens are also part of the routine clinical laboratory testing. So we need to pay attention to those specimens from biosafety protection perspective. And for the susceptible population, generally all people are susceptible to this virus. And that understanding of the virus has been deepened. In the early stage, people assume that children are less affected by this virus, but now with the big data support, and then the data shows that all population, the whole population is susceptible to this virus. 87% of the patients fall in the age of 37 to 79 years old. So we need to pay attention to the age group, and for the severe case patients, age is a key factor for us to pay attention to. Later on, I will elaborate on that as well. And on this slide, for COVID-19 virus, under different scenarios and circumstances, we conduct different studies, and the survival time of this virus varies. Under aerosols or on the surface of copper, on the cardboard, on steel surface, on plastic surface, the survival time varies. The smoother the surface is, the longer the survival time of this virus, and that means within our environment, we need to pay attention to biosafety protection, given different scenarios, especially for the environment and where patients lingered. We need to conduct effective disinfection, sterilization measures. Second part, let's take a look at the epidemiology characteristics in China setting, from local outbreak to community outbreak to large-scale transmission. We went through these stages, and WHO announced us on January the 30th, 2020, it announced that this COVID-19 outbreak as a public health emergency of international concern. At this point of time, actually, it is a great reminder to everyone. Everyone should adopt a proactive, aggressive approach to contain this epidemic. And in China, we have heard a lot of sad stories and tragic events. A certain number of medical staff got infected by this virus because of the working reasons. Medical staff are at a high-risk group. But pleasingly, on March 7th, we have seen some positive signals, because in China, totally 40,000 medical staff are assigned to Wuhan area, to Hubei area. Among the total number of the medical staff, 0 infection. So despite the fact that the medical workers are at a high risk, as long as with good, sufficient biosafety protection, we definitely can win this fight to achieve 0 infection. Biosafety protection is the key. And in the 7th edition of the clinical guidance of diagnosis and treatment in China, there is a new revision and addition, which is the pathology part. Pathology, our understanding of pathology would help us a lot to guide our diagnosis and treatment, as long as we know the change, the development of the pathology and the physiology change, and then we will know then why some physiological index would change. And within the lungs, and we will see there's a consolidation, insulation, mononuclear cells, lymphocytic infiltration, intravascular hyaline thrombosis, coronavirus and particles were found in the cytoplasm of a bronchial epithelium and type 2 alveolar epithelial cells. And for this description, for in vitro culture of COVID-19, that this virus can be detected on the alveolar cell. So that means this virus would invade lungs. That's why sometimes we call COVID-19 as a COVID-19 pneumonia, because this is the many symptoms will be found on lungs, but we need to pay attention to other organs would be suffered as well. With the change in pathology, we know why those changes happen clinically. From pathology standpoint, in the spleen and also in lymph nodes, the CD4 plus T and CD4 positive T cells would decrease in spleen and lymph nodes. So later on, I will elaborate on that. The for the white cells for COVID-19 patients, the level would be normal or decrease. Lymphocytes could reduce among COVID-19 patients. Another point, the decrease of the generation of bone marrow. So clinically, we will see in our blood routine test, we'll see the white cells and might decrease, and lymphocytes might decrease. And in cardiovascular system, clinically, we'll see the cardiomyocytes were denatured or necrotized with inflammation and thrombosis. We can see the increase of our cardiomyocyte or abnormality of this. And for coagulation index, among COVID-19 patients, we see abnormality regularly. And for livers and gallbladders, we will see development increase of our livers with inflammation and high gallbladder filling. Clinically, the ALT will be increasing, and kidneys might be necrotic as well, with a thrombosis. And within the brain tissue, we might detect congestion and edema. So we cooperate with our ICU department. One patient of ours, nucleic acid tested positive, and also the brain tissue was congested. So we detect the COVID-19 virus from the fluid specimen of that patient's brain as well. So clinical features-wise, we can see in terms of incubation, 1 to 14 days compared to SARS, the incubation is longer. And as I said, for asymptomatic patients, it is also the source of a transmission. So long incubation and asymptomatic people could be the source of transmission. Prevent and control of COVID-19 is vital. But most of the COVID-19 patients' incubation length is 3 to 7 days. Clinical manifestation-wise, we can spot a fever, dry cough, and fatigue. For newborns, we haven't seen any obvious clinical features. Most of the patients have a good prognosis, but the elderly and also patients with chronic basic diseases might have a worse prognosis, and that's in line with our clinical testing results. So with our laboratory testing, we can see the elderly and also the patients with chronic basic diseases are prone to be developed as to critically ill patients. And in the 7 additional clinical guidance, it also talks about the prognosis of the COVID-19 pregnant women share the similar clinical course with patients at a similar age. So the disclosed incubation time is 1 to 14 days, but I was also told the longest incubation period is 21 days, even though it's rare. Clinical features-wise, laboratory testing has 2 parts. First, regular testing, serology testing, etiology testing. For the regular testing, we talked about and blood routine test, and later on, I know the Professor Mao is going to elaborate on that. And we also detect some patients with the abnormality of ALT and cardiomyocyte, and the abnormality of inflammation factors. These are the features from routine test. And the second major part, etiology and serology test. For these tests on COVID-19 diagnosis and treatment, they play a vital role. Every time during our diagnosis process, a nucleic acid test, it is a powerful weapon. It has a strong demand. So etiological test, we can use the nasal swabs, sputums, or the lower respiratory tract and specimen, we can detect the RNA of COVID-19. But for the lower respiratory tract specimen, the positive rate is higher. So in our laboratory, we have done around 5,000 nucleic acid tests, and our finding is that the positive rate of sputum is the highest. So in order to increase the positive rate of the nucleic acid rate, if it's possible, we should try our best to collect the sputum specimens. If the patients without sputums, then we can consider to collecting the oral or the throat or nasal swabs. So this is a nucleic acid test. And for the serology test, in the 7th edition of a clinical guidance, it is an addition, it is added. Once this is proposed, that adds more work pressure on our clinical laboratory because the clinical physicians prescribe those serology tests for COVID-19 patients. Let's take a look at the features. So after 3 to 5 days after COVID-19 onset, IgM antibody shows positivity, and the IgG antibody titration during the convalescent period is 4 times and then that during the acute phase. So it is a complementary test to nucleic acid test. But in terms of the test performance, analytical performance of serology test is very high. For serology tests, later on we'll talk about the different methods, because we hope to achieve the high sensitivity and also specificity. So we hope to have the precise, effective serology test kits for us to assist with us. And among different specimens, the positive rate varies. As shown on this slide, this is the study organized by China CDC and with other parties. From this outcome, among different specimens, the positive rate, the highest positive rate is from BALF, 93%. Second, sputum positive rate, then nasal swabs. Clinically, we also use the throat swabs with high positive rate. So ideally, we should collect the BALF specimen, but it's not that easy. So second best choice is sputum specimen. If the patients without sputums, then if we can collect the nasals and oral specimens, and this is good. And we also see the blood specimen positive rate is relatively low. So from nucleic acid testing standpoint, clinically, realistically, we should try to collect the sputums, nasal swabs, and throat swabs as ideal qualified specimens. And then imaging characteristics. So we might detect the patchy shadows, interstitial changes different from influenzas. So from the aforementioned introduction, despite that it is called COVID-19 pneumonia, but centered around the study, we should not see it as a pneumonia. It is not just about a pneumonia, because other organs will also be invaded, be suffered. So through diagnosis and treatment, we need to use a comprehensive approach. With that, let's look at the criteria for diagnosis. In China, we divide them into suspected cases and confirmed cases. For suspected cases, we need to look at the epidemiology history and also clinical manifestation. And for epidemiology history, the first characteristic is that if then 14 days after the onset, because in Hubei province was the epicenter of this virus outbreak. So 14 days within the onset, or if they reside or visit the Hubei area. This is one of the criteria we need to look at. Second, 14 days before onset, they were in contact with positive COVID-19 patients. Third, 14 days before the onset, the patient was in contact with people originally locally from Wuhan or from other peripheral areas in Hubei province. And another criteria is that clustered events. A clustered event is added in the 7th edition of clinical guidance. This definition is important. It means that within 2 weeks, there are small-scale cluster events in families, at homes, in schools. Then a fever or respiratory inflammation symptoms were detected. And for clinical manifestation, if fever or respiratory symptoms are detected, and chest imaging shows COVID-19 features or the abnormalities of nucleocytes and lymphocytes.
So these raised high requirements to the laboratory department. And for confirmed cases, there are 3 criteria. The first is real-time Rt-Pcr testing shows positive results. And second, the viral gene identified by gene sequencing is highly homologous with the known COVID-19. And the third criteria, actually, the third point raises a great challenge to many Chinese hospitals. That is COVID-19 specific IgG, MIG, antibodies positive, or COVID-19 specific IgG antibody changes from negative to positive, or increases by 4 times in the recovery period compared to the acute period. This point is newly added to the latest edition of the guidance. So prior to the publishing of this edition, many hospitals has been conducting nucleic acid testing. And after the third point is newly added to the guidance, many hospitals, many laboratory departments are preparing for the IgG and IgM testing. And next, clinical classification, we have 4 types: mild case, moderate case, severe case, and critically ill case. And the latest edition also has a detailed description of the symptoms of children. And the incidence rate for different types of cases vary greatly. We can see that patients with underlying diseases and senior citizens have relatively high mortality rate. The mortality rate is actually the key criteria for our victory over this COVID-19. Because the majority of the patients are of mild and moderate symptoms, so they can recover with limited treatment. However, those critically ill patients need more care. And the warnings for severe and critically ill cases is also added to the 7th edition. I thought that some questions was about the indicators, the warnings for severe and critically ill cases. Actually, the warning signals are different for adult patients and a child patient. For adult, the first is progressive decline in the number of peripheral lymphocytes. Second is progressive increase in the levels of peripheral inflammatory biomarkers. Third, progressive increase in lactic acid concentration, and last but not least, pulmonary lesions progress rapidly in a short time. And for children, the clinical symptoms are more apparent. First, like increased respiratory rate. Second is poor mental responsiveness and drowsiness, etc. And now let's move on to identification and reporting of cases. According to this guidance, in pathology testing, now Chinese government is requiring new arrivals in Beijing to receive nucleic acid test, and all the patients at fever clinics in Beijing should receive such tests. This is due to the increasing capacity of nucleic acid testing operations. And also the the removement of suspected cases, and the criteria is that the result of nucleic acid test should be negative for 2 times in a row, and the interval should be at least 24 hours between 2 tests. So the interval is slightly different from that in the 6th edition, which was 1 day. As for treatment, for general treatment, the physicians, the nurses will monitor the blood routine, urea routine, CRP, biochemical indicators, etc. As for the treatment for critically ill cases, the kidney function of the patients will also be under strict monitoring. So renal failure and renal replacement therapy are one of the new requirements, one of the new treatments for critically ill cases in the 7th edition. And also there's a new treatment of recovered patients' plasma. As for immunotherapy for patients with extensive lung lesion, patients with severe symptoms whose testing results shows elevated IL-6 level, tocilizumab treatment can be also used. As for criteria for discharge and precautions after discharge, actually, nucleic acid tests also play an important role in all these criteria. First is about body temperature. The second is about respiratory symptom. And the third is pulmonary imaging. Actually, the most important criteria is the fourth one. That is negative result from nucleic acid test for respiratory specimen for 2 times in a row. And again, the interval should be no shorter than 24 hours. So actually, the nucleic acid test is the vital criteria among these 4. So this is why nucleic acid, we face huge workload and pressure when it comes to nucleic acid test, because it's closely related to clinical treatment and discharge. And in some cases, the recovered patients witness reoccurrence of positive result. And the precautions after discharge include a 14-day quarantine after the discharge. And when the recovered patients go back home, they are required to live in a single room and wear masks and avoid going outdoor. And it's also suggested that the patient should go back to the hospital in the second week for further diagnosis. And so the patient will also be subject to further CBC test, nucleic acid test, etc. And the guidance also put forward principles and requirements for transport. The highest priority for the laboratory department is zero infection among technicians, among our own medical workers. If there's any infection among healthcare workers, this will become a huge blow to the entire hospital. So the general principle is that the testing should be carried out in at least level 2 laboratory, and level 3 protection is a must. This is applicable to both nucleic acid test and ordinary specimen test. So these are the interpretation of some of the contents from the Chinese clinical guidance. And my second major topic is the serology laboratory examination of COVID-19. The isolation and culture of novel coronavirus requires level 3 laboratory. So actually, most of the laboratory in Chinese hospital fail to reach this requirement. So this is not carried out in our laboratories. So we may conduct nucleic acid test. The first criteria is Rt-Pcr. The operation of Rt-Pcr test has high requirements. First, the laboratory, for instance, in Beijing, we have the requirements that the laboratory should receive inspection from the regulators, and the laboratory should have relevant qualification. And for instance, the inspection will be about the performance, the level of protection of the laboratory. So and moreover, originally the results from this laboratory will be compared to that from Beijing's CDC to make sure that the result is right. So the requirement for Rt-Pcr is quite high. Many laboratories in China now has the capacity to operate Rt-Pcr, yet the time needed is kind of long. It will take around 4 to 6 hours. So this time length is somewhat too long for the clinical department, yet this test is very important. So we have to figure out ways to carry out nucleic acid tests as soon as possible. And the second technology is nucleic acid sequencing. There's also drawbacks, weaknesses when it comes to these methods. It requires expensive equipment, and also it needs interpretation the result from professional. So few laboratories have the capacity in conducting nucleic acid sequencing. And there are also serology testing for COVID-19. First is against antigen, second is against antibody. The detection of antigen is a good indicator when it comes to the diagnosis of flu. However, the test kit for antigen testing is still underdeveloped, so we haven't found a good test kit for the antigen test. And second, antibody examination. There are also different methods, such as CLIA, ELISA, as well as colloidal gold technique, etc. So the clinical department actually preferred the result from serology testing because it takes a shorter time and the cost is lower and it has lower requirement for the operator as well. The test kit and the equipment needed for serology testing is also more accessible. So here we can see the features of serology testing. First, the specimen is easier to be collected because for nucleic acid test, the collection of specimen require professionals. That means higher requirement when it comes to personnel training. Last but not least, the nucleic acid testing of COVID-19. Actually, this is a long process from collection to transport to storage to examination. And throughout this process, biosafety protection is of vital significance. For instance, it has the staff, the technicians working for nucleic acid tests should be subject to training beforehand, and they should be equipped with level 3 biosafety protection. And multiple specimen collection is also suggested for highly suspected cases. As I've mentioned before, sputum, throat swabs, nasal swabs, and feces and urine can also all of them can serve as the specimen. And the quality of the specimen is also important. We should prioritize lower respiratory specimen. If collection of LRT specimen is not possible, then we should use other specimen like throat swab and nasal swab. And the requirement for specimen also vary from case to case, such as critically ill case and severe case. We used to have a patient from the ICU ward, and we conducted multiple nucleic acid tests to him, and we can see that the results changed from positive to negative and vice versa frequently. And some recovered patients were also tested positive even after his or her recovery. So we will have to come back to the hospital for further treatment. The time point and the site of collection matters a lot. And for the specimen collection for mild patients, we also evaluate the quality of different kinds of specimens, such as throat swab and nasal swab. The positive rate of nasal swab is higher than that of throat swab. So nasal swab should be prioritized before throat swabs. As for specimen collection for critically ill patients, actually we suggest bronchoalveolar lavage fluid. As for transfer and packaging of the specimen, because this whole process involves a lot of departments within a hospital, so it needs coordination between different departments, and we suggest that a container should be used, and the specimen should have 3 levels of packaging. First, the interior packaging, and also secondary packaging, like a container. It should first be put into a tube and then put into a plastic bag. This is the inner packaging. And then it can be put into a secondary packaging, a container. The certificates are not required for specimens transitions between hospital branches of the same hospital. However, if the specimen is to be transferred between different hospitals, a certificate is needed. And the requirement for the container is that the healthcare worker can't take the container even without gloves. So it should be fully sealed. And we also suggest that the test should be carried out within 24 hours of the collection of the specimen. And if not, it should be stored in an ultra-low temperature refrigerator. And just now, I said that to put the specimen in the environment was 56 degrees Celsius for 30 minutes, then the virus can be inactivated. So this is one of the methods we use for specimen inactivation after the test.
Sputum specimens are difficult to be treated and processed because they are quite thick, and so we need to have to use a digestant and to digest it, to treat it. After liquefaction, then we can use it for testing. And for PCR testing, in terms of the test operation, it poses high requirements. So we need to pay attention to the testing of the blank control. For the testing of positive and negative control, we need to use the full process control. We require that the RNA extraction and amplification need to be done in separate rooms. So far, in our laboratory, we use 2 different kits to test on the same specimen. And it is required that the tested genes, we use 2 different test kits to test on 2 different gene regions, including ORF1AB and N, and gene N. If we use double test kit and 2 genes tested positive, the result is positive. If one gene is positive with one single test, with two different tests, it is positive. But if one gene tested positive with one test kit, then and it's tested negative and with another test kit, and then we need to do the retesting. So for nucleic acid test, it has high requirements for our laboratory. Most importantly, safety protection. In level 2 laboratory, we use level 3 protection, including PPE. Later on, I know Professor Mao is going to give a detailed introduction to that as well. Details-wise, it's very minute, including on the table surface, we need to use an layered with a tablecloth and 2 operator operation. and vertical position of the specimen rack, etc. Generally, during the testing, in level 2 laboratory, we use level 3 protection to avoid the generation of aerosol. We strictly follow the defined procedure to operate. In the interest of time, I'm not going to delve into all the details, but generally, in general, staff, people are the key. As long as our people are protected, being safe, so that they can conduct the testing effectively to come back the battle. And most importantly, pay attention to safety during the whole testing procedure. Details are the king. Remember to combine theory and practice together. With that, this is my sharing. Thank you very much for your listening. Many thanks for Professor Wang's for her insightful sharing. Just now, Professor Wang briefed us on the interpretation of a clinical guidance on COVID-19 diagnosis and treatment from laboratory perspective, given their substantial laboratory experience. Again, we would like to thank her for her generous sharing. Next speaker, Professor Mao Hongli. She's going to talk about the significance of the diagnosis and treatment of a blood routine test and CRP for infectious diseases. General introduction to Professor Mao Hongli. So she graduated from Henan Provincial Medical College Laboratory Testing Discipline, and she received her PhD on molecular genetics. Professor Mao has been on blood testing, clinical blood testing for a long time, and also the QMS of laboratory. She's adept at the barrel analysis, refractory blood diseases analysis. Professor Mao subsequently has published 25 papers in core medical journals in China, and she also the editor of 3 medical publications. Without further ado, let's welcome Professor Mao to share her experience and her understanding on the significance of blood routine and CRP results in infectious diseases diagnosis. Thank you very much for Professor Pan's kind introduction. Today, I'm very honored, thanks to the invitation of Mindray, to have this opportunity to share with our Indian colleagues through this webinar. I feel particularly privileged, so I would like to take up this opportunity to share our experience. So again, thank you, Professor Pan. And also, I would like to thank our Indian colleagues for giving me this opportunity. And just now, Professor Wang shared the interpretation to the 7th edition of the clinical guidance of COVID-19 diagnosis and treatment, including a specimen collection, specimen testing, and specimen transfer. And for my part, I'm going to focus on the significance of blood routine CRP test results for infectious disease diagnosis and treatment. And so, since the outbreak of COVID-19 in Wuhan City in China last December, for Henan province, which is an unpopulated province and with a large number of labor force who were actually working in Wuhan City and Hubei province, which was the epicenter of the COVID-19 virus. So, and also Henan province is adjacent to Hubei province. So our incurrence rate of COVID-19 in our province is also quite high. And our hospital, as the largest tertiary hospital, as a designated hospital, so we are obliged to join this battle. So since our hospital was designated for the COVID-19 diagnosis and treatment in our laboratory, immediately we established our dedicated laboratory to conduct a blood routine and CRP test. With the development of this virus, it poses a higher requirements on our clinical index monitoring. So in our emergency lab, we renovated that. We also renovated an area as the micro-negative pressure laboratory so that we are qualified to conduct more blood tests, including microbial subgroup test, etc. So this is the background. And on February the 3rd, 2020, this year, our PCR test laboratory was approved as a qualified lab by our NHC to conduct a COVID-19 nucleic acid test. So every day, at least we run 4 batches of nucleic acid test 24/7. And at this point, I would particularly share our understanding on the blood routine test and CRP test for COVID-19 diseases. So this is the outline of our talk. First is the application of blood routine and CRP test for COVID-19 and the recommended COVID-19 treatment plan and the clinical significance of these 2 tests for COVID-19. Now, let's look at the application of these 2 tests. Clinically, we found that in ICU or in ER or in pediatric department, respiratory department, and we noticed a high number of infectious diseases and a larger number of fever cases. Are they caused by a virus or bacteria? Should we use antibiotics? So many questions are popped up in our mind. So if we cannot use effective clinical index, we will find difficult to diagnose such diseases, and it may lead to abuse of antibiotics. And in 2016, according to the disclosed top 10 on death reasons by WHO, around 13 million of children were infected to death. Every year, 700,000 people died of superbacteria and 230,000 newborns had premature death and because of a bacterial infection. So we need to have a fast and effective screening test to facilitate our triage diagnosis. And for infectious diseases, the ideal scenario is that we use antiviral drugs, and for viral infection, we use antibiotics, and for bacterial infection. But the reality is that many infectious diseases, clinically wise, they are in lack of specificity, so it is hard to differentiate whether they are caused by bacteria or by virus or by other forms of microbials. And it's hard for us to differentiate the severity of those diseases. And that leads to, with the empirical judgment, misuse of the medication or a misdiagnosis might happen. So This is the reality we have to deal with. And so if in our lab, if we can select an effective test to differentiate the disease infection type, it is very significant. And in our clinical laboratory work, these are common markers of infections, including peripheral blood cell count and classification. What is that? Through our observation, we observe the blood cell count, peripheral blood cell count changes, and also the disease features. So many blood routine text index are very sensitive to physiological changes for infectious diseases. It is infected by bacteria, especially septic bacteria infection, that we will see the increase of the leukocytes. But the specificity is low. So we look at another, for example, CRP, which is another common marker sensitive to inflammation. So when the tissue is damaged, inflammation is incurred, then we will see the jump of CRP from patients. And IL-6, it is important synthesization factor for CRP. And for bacterial infection, CRP would be up, and for viral infection, CRP would not increase significantly. We also look at ESR and PCT. For sepsis, that we will see the rise of a PCT. So PCT could be an effective exclusion factor for us to look at whether this disease is caused by virus or bacteria. So we use an integrated automatic and blood cell analysis platform to run these tests. If we combine these two tests together on the same test platform, we will shorten our testing cycle to provide a timely clinical indication to our physicians. And usually, if there's infected by bacteria, then the white cells will be up, especially neutrophil. For example, E. coli and typhus, we will see the rise of a neutrophil. And for viral infection, a neutrophil might decrease. For viral infection, neutrophil rise would just be very mild. So for viral infection, we also need to look at lymphocytes. For example, hepatitis. We will see the decrease of a neutrophil, but the rise of lymphocytes. Another kind of infection, for example, measles, or pertussis, we will see the rise of lymphocytes. Another kind of parasite infection, then we'll see the disease caused by cytomegalovirus. So CRP test is effective for us to monitor the cause of infectious disease caused by bacteria or virus. So we will look at the IL-6 and the cytokine, and when the CRP is generated, we will also need to look at other exogenous factors. So CRP will activate the complementary system with the IgA receptor to strengthen the activity to strengthen the immune system. And for bacterial infection, CRP jumps immediately. Bacterial infection happens outside the cells, so CRPs would get binded and synthesized fast. So the inflammation will be expanded for viral infection. It happens within the cells. So CRP would be difficult to be binding. So we would just see the mild increase or the flat line of a CRP. And for COVID-19, CRP increases though. So CRP is a sensitive index. It responds fast before the rise of leukocytes. And it's aligned with the course of disease. So the blood routine test combined with the CRP test are vital screening strategy for us. So for COVID-19 testing, the changes of a CRP value are quite significant. So it is one of the important indices for us to look at, and it's included in our COVID-19 diagnosis and treatment plan.
NCPC and CRP has been widely used in the diagnosis of major pandemic. For instance, in SARS, MERS, and H1N1 epidemic, CPC and CRP has been used for the diagnosis. And in the study of SARS outbreak back in 2003, a study was conducted in neutrophil count at CRP level. And the methodology was a single factor regression analysis. And we found significant difference between SARS patient and healthy people. And as for H1N9, in the outbreak of this type A flu back in 2009, and the studies for CRP and PCT level against H1N1 patients found that their levels can also be used to differentiate the diagnosis of this influenza. And we found that the AUC of CRP and PCT in a differential diagnosis of influenza pneumonia were 0.75 and 0.78 respectively. With higher cutoff value, the sensitivity and specificity will be higher as well. The sensitivity was 81.8 and specificity 66.7% when the PCT cutoff value is greater than 0.35. So with CRP and PCT level, we can carry out hierarchical management of the epidemic outbreak. And during the MERS outbreak, a regional perspective study was also conducted. And the objects of this study is CRP and blood routine parameters. And it was found that they can be used to predict the prognosis of patients. If CRP is greater than 4 milligrams, and if there's reduction in lymphocyte or platelet, then it can help to predict the later development of the patient's condition. And last but not least, I would like to talk about the recommendation about the treatment plan of COVID-19 pneumonia. Nucleic acid test and serology test has played a role in the diagnosis of the disease. The coronavirus outbreak was first happened in China in December 2019, And in January 2020, a laboratory detected a previously unknown coronavirus. And on January the 12th, 2020, WHO officially named this coronavirus as 2019 nCoV. And in January 2020 was the approval from the China's State Council. COVID-19 pneumonia was included in Class B infectious diseases, the basis of law on prevention and control of infectious disease of PRC. And Professor Wang has shared with us some facts about the nucleic acid test, and she's interpreted part of the contents from the Chinese guidance. I will not repeat on that. So this is also the etiology features of COVID-19, and this is an important baseline for our understanding of COVID-19. I will not go into details as Professor Wang has talked about it. As for the role of laboratory examination to specific treatment. When there is bacteria infection, in infection, the number of lymphocytes will decrease, while when there is virus infection, the number of lymphocytes will remain the same, and the number is normal. So throughout the development of a disease, the peripheral blood lymphocytes will decrease progressively. This has been observed repeatedly. And as for critically ill patients, they could have increase of liver enzyme, LDH, muscle enzyme, etc. So these are the results of laboratory examination. So these results can serve as the guideline for clinical treatment. And monitoring is also important part of the clinical treatment of COVID-19. And for instance, indicators like liver enzyme, myocardial enzyme, renal function are under monitoring. And the monitoring of these indicators can serve as the guideline for the effect. They can reflect the efficacy of the treatment. For instance, if the number of white blood cell increase, then that means the patient is slowly recovering and the treatment is working. So the result of the CBC test and CRP can reflect the effectiveness of the treatment. And the result can also be used as the clinical warnings for critically ill cases. For instance, for adult, if there are these four kinds of scenarios happening: progressive decrease of peripheral blood lymphocyte, expression of IL-6 and C protein in peripheral blood increase, lactate increase progressively, the lung disease develop rapidly in a short time, and special attention should be paid to the patient, as these serve as the warning signals for critically ill cases. So for mild cases and moderate cases,
So one of the diagnostic criteria is the clinical manifestation of the decrease of leukocyte count and lymphocyte count in blood routine test, and blood routine test and CRP as auxiliary examination and clinical warning of inflammation and disease development process. And again, aerosol. Aerosol can be generated during the process of testing. So how to avoid the generation of aerosol and protect our medical staff, this is of vital importance. So we've compiled a defined process for the testing, for laboratory examination. And we've studied the specimen collection, transport, testing, as well as the infection of the environment, waste disposal, and the handlement of accidents. And these guidelines include 11 aspects so as to guarantee the absolute safety of our laboratory. So this is the biosafety handlement procedure, processing procedure issued by our laboratory. There are 11 sections from pathology to epidemiology. We've covered as many aspects as possible, and we issue this manual, this guideline to local laboratories. And in this way, we've also achieved zero infection among our medical staff. As for biosafety protection, we have stipulated that technicians of specimen collection must be subject to training in biosafety and experimental skills. And after the after the specimen is collected, during the specimen transfer, the outer container, when entering the laboratory, should first be disinfected. In this way, we can guarantee that the outer surface of the container does not have any virus and will not generate aerosol. And then the sample will be put into the secondary interior container. The secondary interior container will be put into a specialized container for transfer. So the container for transfer will be transported by trained operators. And we also set a fixed transmission. We also set a fixed transfer route for specimen sending and receiving. After the specimen is sent to the laboratory, the technician within the laboratory will first disinfect the container with chlorine-based disinfectant and open the container in a biosafety cabinet. And then take out the specimen. This is the process, the operation of the non-processed specimen. And all these operations should be conducted in level 2 biosafety lab. And for the operators, level 3 biosafety protection is required. The specimen sent to the laboratory after being taken out of the container and taken into the biosafety lab, the biosafety cabinet, we will first check the information of the specimen to see if it's complete or not. And the specimen to be centrifuged will be put into the centrifuger machine. And if it does not need to be centrifuged, we will put into relevant machine directly. But we will have to let the specimen sit on the rack for 10 minutes to avoid the generation of aerosol. Moreover, after the centrifugal is done, the tube, the specimen should remain still for 10 more minutes. If there is accident or malfunction to the centrifugal machine, we will have to disinfect the centrifugal machine and wait for another 10 more minutes. Moreover, processing of the biosafety cabinets is also required with 75% ethanol, and the method is wipe disinfection instead of a spray inspection. And after that, we will open the ventilator and keep the biosafety cabinet well ventilated. And after that, we can start the next operation within the cabinet. So these are the uncapping of the specimen tube. After the uncapping in the cabinet, we will do batch testing. So we have the machine dedicated to the test of the COVID-19 cases, and other specimen and specimen for other tests will not be conducted on the designated machine. As for CBC test, because we do not have to uncap, open the tube, then actually CBC test of COVID-19 is safer. Can you hear me clearly right now? Because just now there was some disconnection and there were some noises. And my screen sharing was somewhat blocked. So Professor Mao will share her screen again. So we have adopted an assembly line which is fully automatic for puncture and closed injection. So during the process of puncture, after the puncture needle comes out, some blood will remain on the cap. So the specimen tube should remain vertical, and the outer surface should be disinfected after the test. The test container must be closed immediately after the test. So throughout this process, we can avoid the formation of aerosol and reduce diffusion. As for medical waste disposal, we divide them into two parts: waste disposal and waste liquid treatment. The waste liquid cannot be poured into the sewage treatment system of the hospital because it will cause secondary pollution. So we use disinfectant containing chlorine for full inactivation, and then we can put the waste liquid into the sewage treatment system. And as we have mentioned before, we can inactivate the waste liquid by 56 degrees Celsius for 30 minutes. However, this will cause some other problems. So what is our practice? So first, we measure the volume of the waste liquid. Then we will calculate the density needed for the disinfectant. Then we will add this disinfectant to the waste liquid tank. So throughout this process, the waste liquid remains in the waste liquid tank, and the density of disinfectant is high. So in this way, we can carry out full and complete inactivation of the waste liquid. And other waste will be put into 2 layers of yellow medical waste plastic bag. And the outer surface of the medical waste bag will also be disinfected. And for shop tools, they will be disposed in the tool boxes.
So we need to register the waste and after being treated by autoclave, including the weight and the transfer time, who handle them. And if it's related to COVID-19, then we should label it as well. So, and the registration will be archived for 3 years and to have the strict control of the contamination prevention. No matter how well you are doing, no matter how good your procedure is, the key is people. No matter how good your safety protection is, but if your staff are lacking the safety awareness, hazards are prone to happen. So training is vital. With our practice, we conduct continuous theoretical and hands-on trainings and to deepen their understanding and awareness of biosafety protection, so they will be self-reminded and very alert about every potential hazard. And our training covers 2 parts. In our laboratory, including level 2 protection for the specimen delivery staff and level 3 protection for lab operators. And for level 2 protection include a medical mask or N95 mask, latex gloves, isolation gowns, medical caps, disposable shoe wraps. But for level 3 protection, it's required to have N95 mask, double layer latex gloves, goggles, shoe wraps, etc. So throughout our training, we should inform our staff on how to put on their protective suits and how they dig down the protective suits, followed by the defined procedure. The sequence of put on the different layers of protective suits all are based on our defined procedure. Some precautions, for example, before putting on the gloves, we need to check the air tightness of the gloves. For the surgical masks, we need to use our both hands to press on the edge of the mask and to be close to our nose wings, etc. And for the protective suits, it needs to cover the inner layers of the operators and clothes, and the cuff of the protective suits need to cover the inner layer. And when it's degowning, we need to pay attention to prevent the contaminated area being in contact with the inner layers of the clothes. And we strictly follow 7-step hand washing procedure. So how to take care, how to use all the PPE to ensure the biosafety. Next, I am going to talk about the significance of blood routine test and CRP test for COVID-19. The total lymphocytes and the total CRP can be key index to monitor the severity of COVID-19 pneumonia. So in this clinical study, among the 1,099 confirmed cases, 88.2% of the patients with a decrease of lymphocytes, with 60.7% with increase of CRP, and for severe patients, 96% of severe patients with a decrease of lymphocytes. So with big data analysis, the test of lymphocytes and CRP can be the reference to judge the severity of COVID-19 patients. And so among the 138 confirmed cases in Wuhan, this is the retrospective study. We analyze the survival rate and the non-survival rate. So among the 28 survivors in different stages of the disease, you can see the changes of the lymphocytes are not significant, but for the non-survivors, you can see the significant rise of the lymphocytes. And for the neutrophils, which take up the large percentage of the lymphocytes, so the curve is in line with the lymphocytes curve as well. For severe cases, that the neutrophils will also increase significantly. So you can see the distinction between the change curve of the lymphocytes and neutrophils between the severe cases and mild cases for COVID-19. And we also discovered that age is an important factor affecting the severity of COVID-19 cases, and the lymphocyte count and the CRP concentration testing are vital index. And age is also another important factor. We found that generally mild cases occurred among the young population. 87% of the patients of mild cases are young, and 13% of the confirmed cases who are severe cases that they are at elder age. And in terms of gender and the basic diseases, in terms of gender, gender is not an important factor affecting the severity. NLR is also another important factor in the severity of COVID-19. What is NLR? NLR, it is in the peripheral blood. This is the absolute value ratio between neutrophil and lymphocytes. So NLR is about the change of the neutrophil and lymphocyte for COVID-19 patients. The count of neutrophil and lymphocytes, the neutrophil count is much higher than normal people, and lymphocyte count of COVID-19 patients are much higher than normal people. So with this NLR, once we get the absolute count, the absolute number of the neutrophil and the lymphocyte count from the blood routine test, we can calculate this NLR, which is very useful for us for COVID-19 diagnosis, and that would help clinical physicians to identify COVID-19 patients and non-COVID-19 patients. To increase the diagnosis precision for COVID-19 patients. With this NLR, with this, you can see the AUC area and sensitivity specificity are much higher than MindrayIndia and CURB65. If we integrate these parameters, we will see after the integration, there's no huge difference compared to the single parameter of NLR. So that means that the NLR is a good index and to monitor the severity development of COVID-19 patients. So age is another important factor affecting severity. So if we include the age and NLR, both factors, then we can use that to achieve a triage diagnosis for COVID-19 patients. If the patient's age is lower than 50, NLR is less than 3.13, then they can be treated in community hospital or do home quarantine. But if they are older than 50 and NLR is larger than 3.13, then they should be treated in isolated ward. And for COVID-19 infected population, if they are elder than 3.13, they should be transferred to ICU. And if they are older than 50, but the NLR is less than 3.13, then they should be treated in an isolated ward with respiratory monitoring and supportive care. So I should say for COVID-19 patients, by given their age and NLR level, we use the age of 50 as the cutoff and NLR of 3.13 as the cutoff, and we can achieve the quick triage diagnosis and treatment for COVID-19 patients. And we can easily get this NLR parameter from blood routine test. So for the admitted patients from Wuhan Hankou hospitals on COVID-19, we done the analysis with these parameters, and the data comes from Wuhan Hankou Hospital from January 21st until February 5th. 555 COVID-19 patients were admitted by this hospital. So after analyzing the age, limb, neutrophils, and then CRP, ALT, then we find out that all these parameters are correlated to the severity of those patients. And so we monitor these parameters closely. And with the multivariate regression analysis, we found that age and CRP combined can predict the mortality risk in the next 12 days. With the data from the Wuhan Hankou Hospital, from the follow-up visit of the patients until February the 5th, and 39 death cases. And with this single variant and regression analysis, we found that CRP, age, lymphocytes, ALT, total bilirubin, and creatinine, albumin, and diabetes are closely related to the death possibility of the next 12 days. And with a multivariate regression analysis, we found that only age and CRP level can predict the patient's mortality probability rate of the next 12 days. The higher of these values, and the higher the probability of death for those patients. So with the ASB mortality risk and factors, it will help us to conduct the triage management for COVID-19 patients in 3 levels. Patients of different levels, so we conduct different risk management. The lowest level, level 1, death probability 0%, and the highest risk level, level 3, with a 30% of the death rate. So those patients should be transferred to ICU so that we can increase in our diagnosis and treatment efficiency and accuracy. And in terms of the blood routine parameters, including neutrophils, lymphocytes, NLR, and RDWSD, we found that these are closely correlated to COVID-19 patient severity as well. So with the data of 45 COVID-19 cases admitted by Jingzhou Central Hospital in Hubei province, we conducted a blood specimen analysis and used it compared with the specimens of mild cases, between mild cases and severe cases. On these parameters, we found that the parameters of neutrophils, lymphocytes, NR, and RDSW, for the severe cases, they are much higher than the common cases. But the lymphocytes of the severe case, the LYM of the severe cases is much lower than the common cases. We also use the NLR and RDWSD as the fitting parameters to identify the common cases and severe cases of COVID-19. And the AUC is a 0.94. So I should say this approach would increase our diagnosis efficiency for severe cases. And NLR, for NLR monitoring, the best AUC is 0.58. But if we combine NLR with the RDW and SC to differentiate the common and severe cases, then the AUC is 0.94. With this fitting parameters, the AUC will be increased to 0.94. We say the ideal AUC is 1. And when these two parameters are fitted together, the AUC is reaching 0.94. That means that this is a very accurate index for us to monitor the severity of COVID-19 patients, to differentiate the common cases from severe cases. And when these conditions are met, we can see the sensitivity can reach 90%, specificity can reach 84.7%. So with our experience, we think that this is an effective approach. We can also do the comparison study to look at the lymphocytes percentage and RDWSD between COVID-19 patients and influenza A and B patients. We found that there's a huge difference between COVID-19 patients and influenza A/B patients. for COVID-19 patients. In the 7th edition of a clinical guidance of COVID-19, for COVID-19, we need to differentiate the COVID-19 from other respiratory infectious diseases. We know for influenza A and B, they have similar symptoms as those of COVID-19, such as coughing, fever. So that means that we need to have better index to identify COVID-19 patients effectively from other respiratory infectious diseases so that we can achieve early detection, early diagnosis, early isolation, and early treatment to align with our strategy. So among the 42 COVID-19 cases admitted by Nanchang Municipal Hospitals, and also we used the 63 influenza A cases, 34 influenza B cases, we found that in terms of lymphocytes percentage and RDWSD, the mean value of P has significant difference. So we suggest to use the lymphocyte percentage and RDWSD as one of the diagnosis reference to identify COVID-19 patients from other respiratory infectious diseases. So this is a screening significance for us to use the lymphocyte percentage and plus RDWSD as integrated parameters.
And the binarily logistic regression analysis of lymphocyte percentage and RDWSD in patients with COVID-19 and patients without it was carried out by SPSS. The results showed that the p-values of lymphocyte percentage and RDWSD were less. And now, on this slide, this is a confirmed case from my hospital. I will not go into a lot of details. And on January the 25th, this patient tested positive of COVID-19 and was admitted to our hospital on, she was admitted to our hospital not in January, but in February. And because this patient was in pregnancy and she also went through delivery at the end of January and was admitted to our hospital at the beginning of February. And we can see that the white blood cell has been on the rise, while the absolute value of lymphocytes was low. And with our treatment, this patient received a plasma from recovered patient. And after that, the number of lymphocyte and white blood cell has been on the rise, and she is gradually recovering. And after the injection of the plasma of recovered patient, we carried out CBC test for this patient again. So now this is the result for the test carried out on the 23rd, and the previous one was on the 22nd. And we can see that she is recovering as the percentage of lymphocyte and white blood cell are all increasing. So this is a case of a confirmed case. We can see that the result of her blood routine test show that our antibacterial, antivirus treatment and the plasma of recovered patient therapy has been effective. And the result of all these indicators are improving. So with my experience in my hospital, and I've shared with you the role of blood routine test and CRP result in the diagnosis and treatment of COVID-19. For instance, the NLR, NEU, CRP, and the RDW-SD, all these parameters can be used and be considered for the comprehensive diagnosis of patients' physical conditions. It can also be used for risk prediction and the prediction of prognosis. So this is all my sharing today. Thank you.